Today, we are on site at McCormick Place in Chicago at the 2019 ASCO annual meeting. We have recapped some of the top news presented from the conference, and soon we'll speak with Dr. S. Vincent Rajkumar on the most exciting multiple myeloma studies and Dr. Sara Tolaney on the pivotal breast cancer abstracts. Welcome to OncLive News Network. I'm Gina Columbus. In the phase 3 Cassiopeia study, the combination of the HER2-targeted therapy, margetuximab with chemotherapy, improved progression-free survival compared with trastuzumab and chemotherapy in pretreated patients with HER2-positive metastatic breast cancer. Currently, overall survival data are maturing. Moreover, CD16A genotyping suggested a differential benefit in patients with a 158F allele. Also in HER2-positive breast cancer, neratinib plus capecitabine led to a significant improvement in progression-free survival compared with lapatinib and capecitabine in patients with HER2-positive metastatic breast cancer who were previously treated with at least 2 HER2-directed regimens. Additionally, there was a trend towards improved overall survival in the neratinib arm, as well as delayed time to intervention for symptomatic central nervous system disease. In terms of tolerability, the two arms were similar. In chronic lymphocytic leukemia, 3-year follow-up showed that acalabrutinib combined with obinutuzumab was associated with high, durable, and deep response rates in patients with both treatment-naive and relapse-refractory disease. In the phase 1b/2 trial, 19 treatment-naive patients and 26 relapse-refractory patients were treated, and the median age overall was 61 years. A 5-year analysis of the long-term effects of the frontline combination of dabrafenib and trametinib in patients with BRAF V600 mutant, unresectable, or metastatic melanoma showed the regimen continues to have durable long-term benefit. Regarding tolerability, no new safety signals were observed with the combination, and there were no treatment-related deaths. In EGFR mutant non-small cell lung cancer, results of the RELAY trial show that the frontline combination of ramucirumab plus erlotinib improved progression-free survival compared with ramucirumab and placebo in EGFR mutant metastatic NSCLC. Moreover, the safety findings were consistent with the established tolerability profiles of each agent alone. Also in melanoma, updated results of the CheckMate 204 trial showed that first-line nivolumab combined with ipilimumab led to a high rate of durable intracranial responses in patients with symptomatic melanoma brain metastases. However, longer follow-up is needed in an effort to understand mechanisms of resistance to PD-1 CTLA-4 inhibition. For a full review of all of these studies, please visit OncLive.com. Here now to discuss some practice-changing abstracts in multiple myeloma is Dr. S. Vincent Rajkumar, who is Professor of Medicine and Consultant in the Division of Hematology, Department of Internal Medicine at Mayo Clinic. Hi, Dr. Rajkumar. Thank you so much for being here today at ASCO.
Thanks so much for having me.
Sure.
It's a pleasure.
Yes. So, first off, congratulations on being recognized as the 2019 Giant of Cancer Care in multiple myeloma. What are your thoughts on being recognized with this peer-nominated award?
Oh, this is an incredible honor. I couldn't believe it when I got the notice. OncLive has been selecting some truly great giants in the field of cancer, and to be even on the same stage with them is an incredible honor. Particularly thrilled that Dr. Rai, whom I've adored over like decades, was there to give the award to me. Yeah, well, very special.
It's very well deserved, so congratulations.
Thank you.
So moving on to some of the multiple myeloma studies that were presented at this year's meeting, there's the phase 3 Icaria MM trial, which garnered a lot of excitement this year. So that was looking at the triplet regimen of isatuximab, pomalidomide, and dexamethasone. What are your thoughts on the results of this study?
So the isatuximab, pomalidomide, dexamethasone randomized trial is a trial that used a new monoclonal anti-CD38 antibody, isatuximab. We already have a monoclonal anti-CD38 antibody on the market, daratumumab, so this will compete with that if and when it gets approved. The study shows that isatuximab is indeed active, and patients who took the triplet had a longer progression-free survival and a trend for overall survival benefit. So I'm very excited, particularly for me, since I've been part of the study team. This is very great news that we have one more active drug, and more importantly, I think that I've always been a fan of having competitive drugs in the market which may put some pressure on costs and reduce barriers for access.
That's a very interesting point. Okay. Now, the phase 3 Columbus study evaluated a subcutaneous flat dose formulation of daratumumab in patients with relapsed refractory disease. So how could these findings change practice?
Oh, I think the daratumumab subcutaneous formulation is going to be a very, very big plus. Dara has very quickly, from like the last 4 years, become indispensable in the treatment of multiple myeloma in all stages, from frontline, relapse, maintenance. And the main problem with daratumumab is that it takes 4 to 6 hours to give. And sometimes patients are getting it every single week or every 2 weeks. And it's a burden for patients. And the subcutaneous formulation, on the other hand, is only a few minutes, and like 3 to 5 minutes. And what we found in the study was far less, of course, infusion-related reactions, and also significant response rates comparable to what you get with the IV formulation. So there's no real detriment to the use of the subcutaneous formulation, only benefits. So I'm really looking forward for this formulation to be approved so that patients can have access to this.
Good. Now, part 1 of the Cassiopeia study that explored daratumumab in combination with bortezomib, thalidomide, and dexamethasone in newly diagnosed patients. So how could this regimen fit into the paradigm?
Oh, this Cassiopeia trial was my #1 abstract for myeloma at ASCO. Many reasons why. It's a more than a 1,000 patient study that accrued within 2 years. I mean, that's remarkable. It's not something that we can do in the United States. So the trial was conducted and led by the IFM group in France, and they looked at a 4-drug regimen versus a 3-drug regimen, testing the use of daratumumab in the frontline setting. What they found was, as expected, improved response rates, improved progression-free survival, but more importantly, there was also a trend for an overall survival benefit. Now, this is very critical when you want to use a drug like daratumumab early on. More than progression-free survival, if there's a hint of survival benefit, that really helps, and there was, and that's very impressive to me. Now, and in terms of how does this affect practice, to me, I think the concept that we may have to use 4 drugs to get the best outcomes in newly diagnosed myeloma has been established by this study to some extent. And so I would be ready to use something like that in a high-risk population. The only reason why I hesitate to use it for all patients with newly diagnosed myeloma is, number one, the study looked at only young patients who are less than 65 who are transplant eligible. So that's the group you want to go for. And secondly, the study used bortezomib, thalidomide, dexamethasone with daratumumab, and we don't use thalidomide as much, we use lenalidomide. So there are some data that will come out soon with a 4-drug lenalidomide based combination, and I'll wait for that for some of the standard risk patients. And finally, a little bit more mature data on overall survival before I embrace it for all patients who are transplant eligible. But I think for high-risk patients who are transplant eligible, where there's so much to lose and so much to gain, I think like the use of a 4-drug regimen is something that I'm going to consider as, practice changing even now.
Now, what about in smoldering multiple myeloma? So there are smoldering myeloma. So there's a study looking at in high-risk disease at lenalidomide compared with observation alone. So can you talk about those data a little bit?
Yes, and so with smoldering myeloma, it's an asymptomatic group of patients. These patients, some of them can go for many years without needing any therapy. But on the other hand, we also know like 50% are going to progress within 5 years. And if you use some biomarkers to look for high-risk patients, we know that 50% will progress within 2 years. So if you have a 50-50 chance of getting a serious malignancy within 2 years, shouldn't we be doing something to try and prevent it? And that's what we did in the ECOG trial. We gave lenalidomide versus observation, and we found significant delay or prevention of end organ damage, such as renal failure, anemia, bone disease. And coupled with the Spanish trial, which has already shown the same thing, we think this is practice changing. The Spanish study also showed an overall survival benefit. So Dr. Lonial, who presented the study, myself, and many of my colleagues in ECOG, we feel like the time for high-risk smoldering myeloma to start on some form of therapy is now. What should that treatment be? For right now, the best data we have is for lenalidomide or lenalidomide plus low-dose dexamethasone. We do have an ECOG trial that is just open, which is going to compare something mild like lenalidomide dexamethasone versus a more myeloma-like therapy with a triplet. And that trial is active, and when that trial results read out, we'll know whether these patients should be treated more in a preventive manner or full-blown myeloma therapy.
Good. Great insight. Now, what are some other multiple myeloma studies that are being presented this year that you were really excited about, and what do you think this really says about the way the field is going over the next year?
Oh, this was a very, very good ASCO. We had a lot of abstracts that were presented here for the first time that nobody had any data from before. One of the ones that I really was fortunate to work on, and to some degree, is the International Myeloma Working Group project on risk stratification for smoldering myeloma. Like if we're going to treat high-risk patients, how are we going to identify these patients in a manner that's uniform across the world, that everybody has the test to? So there was a study, over 1,000 patients were studied, and we have a very simple risk stratification model that simply uses the free light chain ratio, the size of the M protein, and the percent of bone marrow plasma cells to select patients for therapy. There was also another International Myeloma Working Group project looking at the natural history of 11-14 myeloma. Now, myeloma is really 6 or 7 diseases called together as one disease, but it's really 6 or 7 individual diseases. And for the first time, we've taken one of those, the 11-14 type, and studied it in detail. There's 800 patients were studied. We established what is the normal median survival, how do they respond to therapy, what other cytogenetic abnormalities will they get. So it's a start for the field to start looking at myeloma as individual diseases. Like we said in a recent paper, the multiple myelomas, rather than one disease. There were also a few new drugs that are active in myeloma that we heard data from. 2 of those were updates. One is the Amgen 420, that's the bispecific T-cell engager that has shown single agent activity. We had updated data on that. That's very encouraging. The other one is selinexor with unique mechanism of action, that also showing some survival signals. And then for the first time ever, we heard the data on the CellMod, a new cell gene compound called CC220. This one is like thalidomide or lenalidomide in a way, but also quite different. And it was studied in patients who had already failed other treatments and shows, again, activity in combination with low-dose dex. So that's encouraging that we are getting even more new drugs for myeloma beyond the many, many drugs we already have. And finally, there was update of a large study that looked at various carfilzomib-based combinations, carfilzomib, lenalidomide dex given for a fixed duration versus continuous versus that regimen plus a transplant, the Forte trial. And this trial shows that transplant may still have value even now with the arrival of new drugs and many other options. So I think all in all, ASCO 2019 was a very good year for multiple myeloma in terms of new research, progress, new drugs. So I was very happy to be here.
Well, we're so happy that we had you here, and thank you so much. Really appreciate it.
Thanks so much, Jess.
Finally, we sit down with Dr. Sara Tolaney, who is the Associate Director of the Susan F. Smith Center for Women's Cancer, Director of Clinical Trials, Breast Oncology, Senior Physician, and Assistant Professor of Medicine at Harvard Medical School. Hi, Dr. Tolaney. We're so happy to have you here today.
Oh, thanks so much for having me.
Sure. So towards the end of this year's meeting, we saw a huge number of breast cancer abstracts, saw the readout of them. Can you share what ones stand really out to you in 2019?
I think one really exciting abstract that we saw were the results of the MONALEESA-7 study. So this was actually the only phase 3 trial specifically for premenopausal patients that looked at the benefits of adding a CDK4/6 inhibitor to endocrine therapy. So in this trial, women were randomized to receive physician choice endocrine therapy. In essence, they all had to get ovarian suppression, but then could get either tamoxifen or an aromatase inhibitor, and then got randomized to receive ribociclib or placebo. And we've previously seen the results regarding progression-free survival, suggesting an improvement from around 13 to almost 24 months, which is very consistent with all the trials we've seen in postmenopausal women in terms of this very impressive improvement in progression-free survival. But what we saw today, actually, at ASCO was the overall survival data, which I think was very impressive. So it's the first study looking at overall survival that's actually had a statistically significant benefit. So what we saw was that there was a 29% reduction in deaths from the addition of ribociclib to endocrine therapy. Again, this is specifically in a premenopausal population. That being said, they are all rendered postmenopausal, and so it does make you wonder if this is something that is going to be a generalizable phenomenon to the other trials, and so we're eagerly awaiting the data from the studies that looked at postmenopausal patients.
Good, okay, great. Now, in HER2-positive disease, we saw some data from the Cassiopeia study with margetuximab and chemotherapy, which has been showing some promising activity compared with trastuzumab. So what's your thoughts on these data?
So this trial, the Cassiopeia trial, randomized patients to receive chemotherapy with margetuximab or chemotherapy with trastuzumab. So margetuximab is a very interesting drug. It's a monoclonal antibody that's directed against HER2, just like trastuzumab is, but has an FC optimized region, so that has increased affinity to CD16A. This is something that trastuzumab actually has a little less affinity to, and so the thought would be that potentially this agent may actually enhance ADCC, increase NK activity, and so may have some increased immune effector function. And so this study did show that there was a statistically significant improvement in progression-free survival. That being said, the difference was small. It was only about a month. And so I do think we're very interested in seeing what the overall survival data says when that is mature. But it does give us a hint that this agent may potentially offer some advantages over trastuzumab, particularly in those patients who have the CD16A F genotype, where we did see that there's even an incrementally larger benefit from the use of margetuximab. And so again, I think we need a little bit longer follow-up, but I think very exciting data.
Good, okay, great insight. Now, also in HER2-positive breast cancer, we learned about the NALA study, which is looking at neratinib and capecitabine in the metastatic setting. So could you discuss these data?
Yeah, so neratinib is an agent that we've had around now. It is FDA approved for extended adjuvant therapy, where it has shown benefit. This study specifically was looking at adding neratinib to capecitabine and comparing it to capecitabine with lapatinib. And so what we found was that there was an improvement in progression-free survival with a difference of about 2.2 months favoring capecitabine and neratinib. But what I think was also interesting was that there was a delay to time to CNS intervention for patients getting capecitabine and neratinib compared to the capecitabine-lapatinib combination. You know, we have some prior data that has suggested that capecitabine and neratinib does have nice CNS activity. There was about a 50% volumetric response when that combination was previously studied in patients with active brain metastases, but now this is really showing a delay to time to CNS intervention. And so I do think I do think it potentially will be a combination that will be approved and available to patients. I think the challenge for us will be how to integrate this into practice, because there are now so many HER2-directed therapies in this particular setting, so in this sort of third line and beyond setting. And so then it becomes a choice of when do you use capecitabine trastuzumab, when do you use capecitabine neratinib, and then what about all the other options that we're going to be seeing in the near future. And so I think we'll be challenged with how to optimize to the sequencing of these agents. But I think particularly for a patient with CNS involvement, this may be a very attractive combination.
Okay. What do you think the future really holds for CDK4/6 inhibition as a whole for breast cancer?
So I think CDK4/6 inhibitors have really changed the way we practice and the way we treat our patients with metastatic ER-positive disease. And I think given the data that we've seen, that's very consistent improvements in progression-free survival, and now data looking at overall survival that was positive in a premenopausal population, you know, I think it suggests that patients with endocrine-sensitive disease really do derive significant benefits from these agents, and it should be standard of care. I think there's a lot of potential ways these agents could change practice in other settings too. There are ongoing studies looking at CDK4/6 inhibitors in the adjuvant setting, and both the Monarch E and Palace trial have completed accrual, and so we are awaiting that data to see if these agents will become available for that population. Penelope B also looked at using CDK4/6 inhibitors in patients who failed to achieve a pathologic complete response to preoperative therapy, and so again, we're awaiting those data. And I think we're also now left with the question of what do we do after someone progresses on a CDK4/6 inhibitor? And this is an area that, you know, we really are awaiting further data on. We did see at ASCO some data. One was from a study that looked at this, was the Trinity trial, which really looked at a triplet combination, exemestane, everolimus, and with ribociclib, which suggested a 5.7-month progression-free survival. it's just hard to know how that would compare to exemestane everolimus alone, since this was not a randomized trial. And so I think we really do need to see results from randomized studies to know whether or not there'll be benefit to continuing these agents beyond progression.
Good, good, great insight. Now, just kind of taking a look at all these data that we've seen over the last couple of days, what do you think this really says about the future of breast cancer treatment?
I think it's so hopeful. There's so many new and exciting drugs that continue to come around. You know, even in the HER2 session, we saw data on margetuximab, paratinib, neratinib, and you know, there's just so many new agents that continue to evolve, and even immunotherapy is seeing the survival benefit that we're seeing with atezolizumab in combination with nab-paclitaxel. So I think we're all very hopeful that will continue to improve outcomes for our patients.
Great. Well, Dr. Tolaney, thank you so much for being here today. We really appreciate you sharing your insight on all the breast cancer data.
Oh, thank you.
That's all for today. And don't forget, the OncLive Global Expo is taking place October 11th through 13th in Orlando, Florida. Join us for a fully interactive meeting that brings together the most inclusive group of oncology professionals to collaborate on emerging trends and technologies in oncology care and research. Thank you for watching OncLive News Network on location. Signing off from the 2019 ASCO annual meeting, I'm Gina Columbus.